Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with a very important session. Today we are going to read about the role of immunofluorescence in skin lesion. Now this is the part 3 of the series that we have started. So in the part 1 we have read in details about the basics and the working principle of immunofluorescence, as well as we have read in details about immunofluorescent microscopy. In the part 2, we have read about the role of immunofluorescence in diagnosis of kidney disorders or glomerular disease. And today in part 3, we are going to complete this particular series by reading about the role of immunofluorescence in skin lesion. Now remember, this is a very commonly asked long answer question in the exam, and every alternate year this question will be there. Okay, so please pay a lot of attention in today's topic of discussion. So without wasting any time, let us begin today's topic of discussion. Now, before we proceed towards the understanding of the immunofluorescence finding in the different skin disorders, it is very important that you read two important lectures which I have already covered. One is the vesiculobullous lesions of the skin, which has already been covered previously, and another is SLE, which is covered under general pathology. Now, it is very important for you to read. Why? Because in today's topic of discussion, we are only going to concentrate on the immunofluorescent findings in different skin disorders. We are not going to discuss about the pathogenesis in details. We are not going to discuss about the light microscopic findings in details. We are only going to concentrate on the immunofluorescent findings. Okay. So without wasting any time and just brushing up some knowledge, okay, so as you know that there are that the skin is made up of different layers, starting from the stratum corneum, granulosum, stratum spinosum, then the basal layer, that is the stratum basalis, and the basement membrane. Now if you see the individual cells or the keratinocytes, if you see, they are bound to each other by means of certain proteins called as the desmosome. Now if you see this small desmosome, this small can be expanded, okay, and there are different types of proteins which are forming the desmosome. So there are multiple components, and among multiple component, one component which is very important is the desmoglein. So in one of the vesiculobullous disorder, that is called as pemphigus, autoantibodies are formed against one component that is called as desmoglein in case of pemphigus. Now pemphigus have different varieties. Out of that, the two important varieties is pemphigus foliaceous and pemphigus vulgaris. Now there are many different types of desmoglein. Two important ones are, one is your desmoglein 1, whose concentration decreases as we are going down, and another is desmoglein 3, whose concentration decreases as we are going up. So in case of pemphigus foliaceous, if you see, autoantibodies are mainly formed against desmoglein 1, whereas in case of pemphigus vulgaris, okay, autoantibodies are formed against desmoglein 1 plus desmoglein number 3, okay, and it's very important for the understanding, okay, of how such blister takes place and why they have such kind of location, okay. Another thing, if you see, there is one other component called as the hemidesmosome, which is attaching the keratinocytes with the basement membrane over here. If you enlarge this particular hemidesmosome, so this is the hemidesmosome as we can appreciate over here. So there is one component, if you can appreciate, is BAPAG2. Okay, if autoantibodies are formed against BAPAG2, it leads to a condition known as bullous pemphigoid. Okay, similarly, if autoantibodies are formed against anchoring filament, which is anchoring the lamina densa of the basement membrane to the dermis, okay, and they are actually over here autoantibodies are formed against the anchoring filaments, which is actually binding the lamina densa to the dermis, okay, then a condition formed that is known as dermatitis herpetiformis. And over here, which antibodies are formed? It is IgA antibodies against the anchoring filament, okay. So I have basically discussed in very short about the pathogenesis of different vesiculobullous disorder. So right now I am just going to skip and we will start off with the immunofluorescent findings. So the mucocutaneous bullous disease or the vesiculobullous disorders, they can be subdivided under three headings. Number one is the subcorneal blisters. Subcorneal means if there are so many layers, subcorneal means which is forming just beneath the stratum corneum. Okay, this is the subcorneal blisters. Then there are suprabasal blisters, when there is a separation of the skin. If you see suprabasal blister, that is the blisters are formed at this level, or separation is there at the just above the basal layer. So we call it as suprabasal blister. And then one of them, you are having subepidermal blister. What is subepidermal blister? When they are forming at the level of the dermal epidermal zone. So below the epidermis, that is subepidermal blisters. Okay. So remember this point very importantly. Though it is very easy to diagnose and differentiate between the subcorneal suprabasal blisters, but there is a lot of confusion with regards to the subepidermal blisters, because many diseases, they are forming subepidermal blisters and they have a very similar pattern on diffuse immunofluorescence. So for that purpose, we are carrying out a procedure known as salt split skin technique. Okay, salt split skin technique is there, wherein you are purposely dividing the skin so as to localize and differentiate between the different causes of subepidermal blister. Okay, so we will discuss about that later on. So first condition, as I told you, is the subcorneal blister, wherein there is a division of the skin at the level of the stratum corneum. Okay, so over here the blister is having a very thin roof. So you can see this is the thickness of the roof which is there for the blister. So the stratum corneum or the thin roof breaks very easily. That is a subcorneal blister. So what are the conditions under the heading of subcorneal blister? We are having miliaria, staphylococcal scalded skin syndrome, bullous impetigo, IgA pemphigus. So out of all of them, the most important one is pemphigus foliaceus and the variants. And you also know why pemphigus foliaceus is basically forming at this level, because majority of the autoantibodies are formed against desmoglein 1 in pemphigus foliaceus, and they are highly concentrated at this layer. So therefore the blisters are also formed at this layer in case of pemphigus foliaceus. Okay. So in subcorneal blisters, the stratum corneum forms the roof of the bulla, as we can appreciate over here. The second type of blisters that we see is the suprabasal blisters. Over here, what happens, a portion of the epidermis, including the stratum corneum, forms the roof and tends to break off. So over here, the level at which the separation is there is somewhere, in the epidermis, just above the basal cell layer, as you can appreciate. So over here, the roof is quite thick, as you can appreciate over here. So in suprabasal blister, a portion of the epidermis, including the stratum corneum, forms the roof and tends to break off. So what are the conditions where you are having suprabasal blisters? We are having pemphigus vulgaris and its variants, paraneoplastic pemphigus, and Derrier's disease. So over here, the prototype disease that we will discuss is pemphigus vulgaris. So as you can see, that the desmoglein 3 is highly concentrated over here at this level, if you see, and also some amount of desmoglein 1 is also concentrated over here. So just above the basal cell layer, you will see separation occurs in case of pemphigus vulgaris. Lastly, we are having subepidermal blisters. So in a subepidermal blister, the entire epidermis separates from the dermis, as you can appreciate over here. Okay, the entire epidermis is separating from the dermis. So over here, a lot of conditions are there that you are going to see, like bullous pemphigoid, cicatricial pemphigoid, dermatitis herpetiformis, linear IgA dermatitis, LIGA, epidermolysis bullosa, erythema multiforme. Okay, so there are multiple conditions where separation occurs at the epidermal basement membrane zone or at the epidermal dermal junction. Okay, so in case of diffuse immunofluorescence, all of them will have more or less a very similar finding. So to differentiate among such conditions, we are carrying out salt split technique. Split salt technique. Okay, split salt technique is followed for differentiating between these conditions. That I will speak what is that. Okay, this is the salt split technique, or it is a modified immunofluorescence. Actually, we are carrying out over here. So over here, we are artificially splitting the skin with sodium chloride, and afterwards on that skin, immunofluorescence, indirect immunofluorescence is performed. Okay, now there are two types of salt split technique. One is the direct indirect type, and remember one thing, the basement membrane zone staining, if you see, you can have different kinds of pattern. Either the separation will be there at the level of the roof in certain disorders, separation will be there at the level of the floor in certain disorders, and sometimes you are having a combined pattern. So depending on what pattern you see, you can diagnose the condition. Okay, so this is the intact skin, as you can appreciate over here. After you treat it with NaCl, artificially we have created a blister cavity over here. Okay, and after that we are carrying out indirect immunofluorescence. So if after indirect immunofluorescence you see the immune complex at the level of the roof or at the level of the floor, so depending on the location, we are going to define a particular disorder. Okay, so this is the salt split technique, which is mainly done to differentiate among different causes of subepidermal blisters. Okay. So it is used to distinguish between subepidermal blistering disease with similar diffuse immunofluorescence pattern. How it is done? you have to incubate the normal or patient skin in 1 mole per liter of NaCl for 48 to 72 hours, which splits the basement membrane at the level of the lamina lucida. Now, if you see in case of direct immunofluorescence, okay, if you see pemphigoid, in condition of bullous pemphigoid, the IgG is present on the roof, or it is present both on the roof as well as in the floor. Whereas localization only to the floor is characteristic of epidermolysis bullosa acquisita. So both bullous pemphigoid as well as epidermolysis bullosa acquisita, they are showing deposition at the level of the epidermis or subepidermal layer. So to differentiate between them, we have to carry out the salt split technique. So after that, when you carry out diffuse immunofluorescence, okay, or you are carrying out the direct immunofluorescence, you will see that basically in case of bullous pemphigoid, IgG is present on the roof or in the roof and the floor. Whereas in case of epidermolysis bullosa acquisita, the immune complex deposition is classically seen only at the level of the floor. So this is how you differentiate between the different subepidermal blistering diseases. So the first condition that we are going to discuss, that is the pemphigus. Now all forms of pemphigus, they are autoimmune disease which is caused by IgG autoantibodies against a group of protein that is known as desmoglein, and that disrupts the intercellular adhesions between the different keratinocytes and results in the formation of blister. So there are different types of pemphigus like pemphigus vulgaris, vegetans, foliaceous pemphigus, erythematous and paraneoplastic pemphigus. So over here we will mainly discuss about vulgaris and pemphigus foliaceous. So first, as you can see, this is the pemphigus vulgaris. So as you can appreciate over here that there is a separation just above the basal cell layer. So can you see this is the separation, and over here you can see this is the basal cell layer, as you can appreciate over here. So separation is somewhat just above the basal cell layer, and these are the keratinocytes, as we can appreciate. And you can see that the antibody deposition, if you see, it is throughout the epidermal layer, okay, and it is in a fish net like or lace like pattern. You can see it is like a fish net like pattern, okay. So it is in between the keratinocytes. You can see that there is antibody deposition. So in pemphigus vulgaris, there is deposition of immunoglobulin along the plasma membrane of the keratinocytes in a reticular or fish net like pattern, also called like a lace like pattern. Accompanied by, along with that, you are having suprabasal loss of cell to cell adhesion or acantholysis. So you are seeing the separation just above the basal layer. And if you see, just as when a person is dying, especially among the Christians, they are putting some stone like this. So this is giving an appearance of a tombstone, row of tombstones. So in one row you can see row of tombstones, okay, like this. So this is giving a row of tombstone appearance. So in pemphigus vulgaris as well as in pemphigus vegetans, acantholysis selectively involves the cells immediately above the basal cell layer. As I have already shown you, the cells are separating just above the basal cell layer. This separation of cell is called as the acantholysis, right? And this is happening suprabasally. So they are producing what is known as a suprabasal blister. Now the single layer of intact basal cells that we can appreciate over here, this single layer of intact basal cell that forms the blister base in pemphigus vulgaris has been likened to a row of tombstone appearance. This is an MCQ. So microscopic image of direct immunofluorescence using an anti-IgG antibody, as we can appreciate over here. So by direct immunofluorescence, the lesion shows a characteristic fish net like pattern or a lace like pattern or a reticular pattern of intercellular IgG deposit. So this pattern is called as the fish net appearance or reticular pattern. Okay, IgG is usually seen at all levels of the epithelium in pemphigus vulgaris, but tends to be more superficial in case of pemphigus foliaceous. So over here in pemphigus vulgaris, we can see that the deposition of IgG is throughout the membrane and separation is at the suprabasal level. Okay, whereas in case of pemphigus foliaceous, you see the separation is between the stratum corneum and the other layers of the skin. So the separation is subcorneal blister formation can be seen over here. The blisters form by similar mechanism, but they are found in more superficial epidermis. At the level of stratum granulosum, you can see blister formation is there. Okay, so this is the stratum granulosum. Over here is stratum corneum, which is forming the roof. So at the level of stratum granulosum, you can see, and you can see maximum deposition of antibody is more in the upper layers of the epidermis. Why? Because desmoglein 1 is concentrated in the upper layer. So a positive result in direct immunofluorescence is the presence of intercellular IgG and complement C3 predominantly within the superficial layers of the epidermis. So this is about the pemphigus foliaceus. Next, we are going to discuss another vesicular bullous disorder, that is bullous pemphigoid. So over here, in case of bullous pemphigoid, as we know, over here autoantibodies are formed against a component called as BAPAG2 that we have already discussed, and BAPAG2 is a component of your hemidesmosome. So let me show you with the help of the diagram that we have already discussed over here. So as we can appreciate over here, we are seeing this is the this is the hemidesmosome, and one of the components of the hemidesmosome is BAPAG2. And where it is basically present at the level of the basement membrane, as you can see. So basically this BAPAG2 component is actually combining with the lamina lucida of the basement membrane. So again over here the separation is taking place at the junction of epidermis dermis. Okay. So over here it is a subepidermal condition or subepidermal blister formation occurs in bullous pemphigoid. So in bullous pemphigoid, it is caused by autoantibodies that bind to proteins that are required for the adherence of the basal keratinocytes to the basement membrane, as we can appreciate. So most antibody deposition occurs in a continuous linear pattern. So as you can see, they are in a linear straight line pattern where at the junction of the dermis and epidermis. So at the dermoepidermal junction, you can see antibody deposition, where your specialized structures called hemidesmosomes are linking the basal keratinocytes to the underlying basement membrane, right? So antibodies are formed against BAPAG2, which is the component of hemidesmosome, which is connecting the basal keratinocytes with the basement membrane, that to the lamina lucida part of the basement membrane, right? So the deposition also occurs at that dermoepidermal junction. A linear deposit is there. So direct immunofluorescence reveals linear deposition of complement C3 and usually IgG along the basement membrane zone, as you can appreciate over here in case of bullous pemphigoid. The next important condition that we are going to see is dermatitis herpetiformis. Okay. So if you see, this is the skin, and if you see, this is basically the epidermis and this is the dermis. So remember one thing, this part which is dipping down, it is called as the reti ridges. Okay, whereas this part which is going up is called as dermal papilla. So over here in case of dermatitis herpetiformis, pathology is lying at the level of the dermal papillae. Okay, so remember this point very clearly. So the lesions that you see in dermatitis herpetiformis, they are bilateral, symmetric and grouped, involving preferentially the extensor surfaces, elbows, knees, upper back and buttocks. Okay, and over here you will see that fibrin and neutrophils accumulate selectively at the tip of the dermal papillae. So I have already shown you what is the dermal papillae, what is the reti ridges. Okay, so this tip that you are seeing where antibody deposition is there. Okay, this tip is actually the dermal papilla. So the basic separation between the epidermis and dermis is somewhat like this, as you can appreciate over here. Let me show you with something lighter. This is how the separation is. And over here, the pathology where it is lying, these are the dermal papilla, tip of the dermal papilla. Over here also some deposition is there. So these are the tip of the dermal papilla where the pathology is there. Now over here, what is happening, that fibrin and neutrophils are selectively accumulating at these points, forming small micro abscess. Now the basal cells which are overlying, now here there are certain basal keratinocytes. The basal keratinocytes which are overlying these dermal papillae, they show vacuolization and focal dermoepidermal separation. So you will see microscopically separation at these level where the basal keratinocytes are in contact with the dermal papillae. Over there you will see that basal keratinocytes are separating from each other. Ultimately, these are going to coalesce, forming a true subepidermal blister. By direct immunofluorescence, dermatitis herpetiformis will show discontinuous granular deposits of IgA that selectively localize at the tips of dermal papilla, as we can appreciate over here. So can you see over here, these are the IgA deposits selectively at the tip of dermal papilla. Okay, this is very characteristic. And which antibody? IgA antibody, autoantibody is depositing over here in case of dermatitis herpetiformis. The next important condition that we see is epidermolysis bullosa acquisita. So by direct immunofluorescence, you are seeing that there is a linear deposit of IgG and complement C3 are present. Okay, just at the level of epidermis and dermis, just at the separation between the epidermis and the dermis, you can see the deposition over here. So over here, the problem is another condition that we had read. They are also showing linear deposit, that is bullous pemphigoid. And so both these conditions are at the level of the epidermis-dermis junction. So both of them are forming subepidermal blisters. So how to differentiate? Because by direct immunofluorescence, both of them are showing the same features. So in this condition, we have to carry out something known as salt split skin preparation. Salt split skin preparation examined with direct immunofluorescence will demonstrate the immune deposits on the floor of the blister in epidermolysis bullosa acquisita rather than the roof of the blister as in case of bullous pemphigoid. So when you carry out the salt split technique, you are going to see that immune deposits are present at the floor in case of epidermolysis bullosa acquisita, whereas they are in the roof in case of bullous pemphigoid. So this is how you are differentiating, okay, between conditions showing linear pattern of deposition at the dermoepidermal junction by salt split technique. The same thing is written over here, so we are not repeating the same. The next important, now we have already covered most of the vesiculobullous lesion. Now we are going to some other conditions which are, for example, this is the chronic inflammatory dermatosis. So not all the conditions are diagnosed using diffuse immunofluorescence. So we are discussing one of them, that is lichen planus. Okay. So over here you are going to see that at the dermoepidermal junction you can see the fibrinogen deposition as a shaggy deposit. You can see that they are shaggy like this. Okay, so they are like a shaggy deposit like this. Only occasionally there are granular deposits of IgM or linear deposits of C3 or both IgG and C3 in the basement membrane zone. Now, not only that, necrotic keratinocytes are demonstrable in lichen planus by direct immunofluorescence staining in about 87% of the cases. And these necrotic keratinocytes are staining mainly for IgM. Okay. Although necrotic keratinocytes are found occasionally in many other conditions with damage to the basal cell layer like lupus erythematosis, they are highly suggestive. Presence of necrotic keratinocytes are highly suggestive of lichen planus if they are present in large numbers or arranged in clusters, and their staining for IgM facilitates their recognition. Okay, so this is about your lichen planus. Next is linear IgA dermatosis. Now, DIF reveals linear IgA along the epidermal basement membrane zone in perilesional skin in 100% of the cases. By direct immunofluorescence, you can demonstrate. Now, over here, one thing is there, that although there is a linear deposition over here, but very importantly, the deposition is that of IgA. And another condition where we saw IgA deposition was in dermatitis herpetiformis, but over there it was at the level of dermal papilla. Okay. Now, over here, in this case also, salt split technique can be used for further differentiation or further subclassification of linear IgA dermatosis. So in the lamina lucida type of LAD, IgA antibodies bind to the epidermal side of the salt split skin, whereas in the sublamina densa type and in the IgA mediated epidermolysis bullosa acquisita also, IgA antibodies bind to the dermal side of the salt split skin. So depending on which side, whether the deposition is on the on the epidermal side, then we are calling it as lamina lucida type of LAD. If it is in the dermal side, we are calling it as the sublamina densa type of linear IgA dermatosis. Next, we are now going to discuss about another important condition, that is cutaneous lupus erythematosis. In the previous lecture, we have already read in details about the role of immunofluorescence in the kidney disorders, wherein we have read about lupus nephritis in details. Now we are reading mainly about the involvement of SLE by the involvement of the skin by SLE, that is cutaneous lupus erythematosis. Three conditions are there. One is your DLE, one is your SCLE, and one is your SLE, that is systemic involvement. DLE is when there is a skin involvement predominantly in DLE and subacute cutaneous lupus erythematosis, and SLE is when there is systemic involvement as well. So in all these conditions, more or less, you see depositions of immunoglobulins and complement components in the skin of patients with lupus erythematosis, which can either be in a linear pattern, or they can be in a granular pattern, or they can be in a shaggy pattern. Shaggy pattern of deposition can be there. So all these three patterns can be seen, where at the basement membrane zone by direct immunofluorescence, and this testing in case of cutaneous lupus erythematosis is called as the lupus band test. Okay, so they can have different kinds of pattern. So the deposition of the immunoglobulins and complement components in skin of the patient with lupus erythematosus, which is demonstrable either as a linear pattern or as a granular pattern or as a shaggy band at the basement membrane zone that is between the epidermis and the dermis. Okay, the demonstration by the direct immunofluorescence of such patterns in lupus erythematosus is called as the lupus band test. Okay, so over here if you see, you can see a very linear type of deposition over here. So linear band-like deposits of IgM along the dermoepidermal junction of a chronic DLE or discoid lupus erythematosus. Now the test is considered positive when one or more of the immunoreactants like IgG, C3, Ig, IgM are found at the dermoepidermal junction. IgG and C3 are most frequently detected. The presence of membrane attack complex at the dermoepidermal junction is relatively sensitive and very specific for lupus erythematosus. Now these are the other patterns, as you can see. Now you can see over here is a very shaggy and granular type of deposition over here. You can see very rough, granular, shaggy type of deposit. So granular deposits of C3 along the dermoepidermal junction of a chronic DLE. I told you either they can be linear or they can be granular, shaggy. So there are different types. Now how do you differentiate SLE from DLE and SCLE? So in case over here, in case of SLE, you will see immune complex deposition around the vessels. So immune complex mediated vasculitis is there in SLE. So perivascular deposits of IgG around the dermal vessel in case of a lesional skin of SLE. These vasculitic changes are specific for SLE and they are not seen in DLE or SCLE. Okay, so this is about your cutaneous lupus erythematosus. Now, not only this, immunofluorescence can also help in the detection of different autoantibodies in SLE. Now, as you know, the hallmark of SLE is the production of autoantibodies, several of which are virtually diagnostic. For example, antibodies to double-stranded DNA or antibodies to Smith antigen. So these antibodies which are directed against the nuclear material, they are collectively called as ANA or anti-nuclear antibodies. So these are directed against the nuclear antigens and they can be divided into 4 categories based on the specificity. Or antibodies against DNA or against histone components or against non-histone proteins or against nucleolar antigens. So the most widely used method for detecting anti-nuclear antibodies is to go for indirect immunofluorescence. And the pattern of nuclear fluorescence suggests the type of antibody which is present in the patient's serum. So 4 basic patterns have been recognized. In fact, there is 5. Okay, there is 5 patterns. So I will show you. Number 1 pattern that you see is homogeneous diffuse nuclear staining, which is very common in SLE. So these are reflecting the antibodies to dsDNA or antibodies to chromatin, histones and nucleosomes. So you can see there is a diffuse staining of the nucleus. Okay, diffuse staining of the nucleus can be appreciated. So homogeneous diffuse nuclear staining seen in SLE, very commonly seen in SLE. Second pattern is your speckled pattern, wherein you see uniform variable sized speckles. So the entire nucleus is not stained. There are certain areas which is dark, which is black, which is not stained. So they are standing out as speckles. So it is called as a speckled pattern. So most commonly observed pattern in fluorescence or in SLE, therefore it is least specific for SLE. It reflects the presence of antibodies to non-DNA nuclear constituents such as the Smith antigen, ribonucleoprotein, SSA or SSB antigens. Okay, so these are basically giving a speckled pattern in indirect immunofluorescence. The third pattern is a centromeric pattern, wherein antibodies are mainly seen against the centromeres. So you can see centromeres, they are involved in division. So you can see how the centromeres over here, they are helping in division, cell division. Some of them are just at the center, they are just starting the cell division. Okay, so these although can be seen, this pattern can be seen in SLE, but they are more commonly seen in patients with systemic sclerosis. This is a centromeric pattern. Another pattern, as you can see, is the rim or the peripheral staining, wherein at the periphery you are seeing the highlighting or the staining or the antibody deposition. It is often indicative of antibody to double-stranded DNA and sometimes against nuclear envelope proteins. Okay, so this is your basic rim or peripheral staining. And lastly, you can see that there are certain areas in the nucleus that only the nucleolus is highlighted, the antibodies against the nucleolar antigen. Okay, so presence of few discrete spots of fluorescence within the nucleus. As you can see, this is the nucleus, the spot is only here. This is the nucleus, the spot is only here. This is the nucleus, the spot is only at the nucleolar region. It reflects antibodies to RNA, most commonly seen in systemic sclerosis. Okay, So this is how we have seen the immunofluorescent patterns in various disorders, especially starting from the vesicular bullous lesion, then again in lichen planus, then cutaneous lupus erythematosus, as well as antibodies which are seen in SLE in the systemic version against the anti-nuclear antibodies, and what are these basic patterns. Okay. Now, I am just going to summarize whatever we have read. So, I am not going in details about all of them because we have already discussed in details about the light microscopy and the diffuse immunofluorescence features. But I have included them that just to complete the list. Okay, I have not given all the immunofluorescence patterns with the photograph because you will get confused in that way. So, in the exam, if you get time, you can just include these entities also, like paraneoplastic pemphigus, pemphigoid gestationis, psychiatrical pemphigoid. Okay, just include them. So what is the immunofluorescent findings over here? In paraneoplastic pemphigus, you see IgG within the epidermal intercellular space and basement membrane zone. In pemphigoid gestationis, you see linear C3 in the basement membrane zone at the level of lamina lucida. In psychiatrical pemphigoid, again you get linear IgG C3 in the basement membrane zone at the level of lamina lucida. Rest others we have already discussed, so I am not discussing them again. Okay, so I have included this so that in the exam, to complete the list, you can add these also. But even if you don't include, whatever we have read is more than enough for your exams to score very good marks. Okay. Now this is again a very important chart taken from Ackerman, if you see, wherein all the different inflammatory dermatoses have been, most of them have been included over here, along with the principal immunoreactants and the pattern of immunofluorescence, which we have already discussed in detail. So again, I am not going into details of that. So thank you very much for watching this particular video. See you in next time.